of the Paediatric Association of Nigeria, I'd like to welcome all of us to the April 2026 webinar. And today we'll be looking at a topic from knowledge to practice, delivering adolescent-friendly healthcare services in Nigeria. I'm sure most of us will agree that adolescent care is one area of pediatrics that most of us shy away from, except for a few brave pediatricians like Onyinye who have decided to take the bull by the horn. So today we have three lovely ladies who will be speaking to us about this issue. But before we start, I'd just like to say that if you have any questions, you can put them in the chat group. Immediately after this introduction, the president of PAN will give a welcome address to be followed by the address of the chairman of the adolescent group, Dr. Bridget Okogwali. Then the introduction will be done by the moderator, Onyinye, and then the presentations. Thereafter, we'll have about 20 minutes for questions and answers, and then there'll be a closing remark. So I will hand over to the president of PAN for her comments. Over to you, Madam President, if you're on the call.
Hello, good afternoon, everybody. The president just landed from a meeting in Abuja. So she's still in transit. So she called upon me to give her welcome address on her behalf. So she expresses her profound apologies and will join us once she's able to. So her address is, welcome everybody. Thank you for attending this webinar. The topic is from knowledge to practice. We welcome you. Thank you. We welcome you to this seminar. This seminar is being presented by our subspecialty group, the Paediatric Association of the Adolescent Pediatric Society of Nigeria, the APSON subspecialty group. We appreciate your effort in delivering this lovely topic to us. So it's my great pleasure to address you today on a subject that is both timely and critical, from knowledge to practice, delivering adolescent-friendly healthcare services in Nigeria. Adolescence represents a pivotal stage of human development marked by rapid emotional and social changes. It's also a period when health behaviors are formed. Behaviors that often persist to adults. Yet, despite this importance, adolescents in Nigeria continue to face significant barriers in assessing quality, acceptable, and appropriate healthcare services. Over the years, we've made considerable progress in generating knowledge through research, policies, and guidelines on adolescent health. However, a persistent gap remains between what we know and what is practiced within our health systems. This gap is what this webinar seeks to address. Today's conversation is not just about sharing information, it's about transforming that knowledge into action. It's equipping healthcare providers with the right skills, attitude, and tools to create safe, inclusive, and responsive environments where adolescents can seek care without fear of stigma, judgment, or neglect. Adolescent health services go beyond clinical competence. They require confidentiality, respect, accessibility, and active engagement with young people. They demand that we listen more, judge less, and design services that truly meet adolescents where they are. As pediatricians and healthcare advocates, we have a responsibility to champion this cause. We must lead efforts to integrate adolescent-friendly approaches into routine healthcare delivery across all levels, from primary healthcare facilities to tertiary institutions. We must also collaborate with policymakers, educators, communities, and adolescents themselves to build systems that are sustainable and impactful. I am confident that today's webinar will provide valuable insights, practical strategies, and real-world experiences that will help bridge the gap between knowledge and practice, I encourage all participants to engage actively, ask questions, share your perspectives. Let us seize this opportunity to strengthen our collective commitment to improving adolescent healthcare outcomes. So on behalf of the President of Paediatric Association of Nigeria, I welcome you all and wish us a productive and an impactful session. Thank you. So I'll hand over to the head, the chairman of APSON, to give us a welcome address and kickstart a well-sought topic. Over to you.
Thank you very much. Thank you very much. I hope you can hear me.
We can.
Loud.
Yes, we can.
Okay, thank you. The distinguished PAN, elders and colleagues, esteemed girls and dear friends, it is a great joy and deep sense of purpose that I welcome you all to this month's PAN subspecialty webinar being hosted by Adolescent Pediatric Society of Nigeria. This subspecialty, as you all know, has been a long time coming, and we are so excited at the prospect, and also for this first time hosting the PAN subspecialty webinar. We are certain that this will be the first of many as we strive to continue to bring the needs of Nigerian adolescents the attention that it deserves, and together tackle the challenges unique to their management. Adolescence is a critical stage, as we all know, filled with the opportunities and unique challenges. As pediatricians, public health experts, and educators, we have the privilege and responsibility to guide our young people through this transformative period. This webinar with the theme, From Knowledge to Practice, delivering adolescent-friendly health services in Nigeria, provides us with a unique platform to share knowledge, exchange ideas, and strengthen our collective capacity to respond to their evolving needs. It is time to move from the textbook and guidelines to the clinic and hospital wards, where we encounter these adolescents. And I'm confident that the insights we gain from our distinguished speakers and the discussions we follow us well and inspire to take even bolder steps in our advocacy and interventions. I encourage you all to participate actively, ask questions, and share your perspectives. Together, we can shape a healthier, more supportive environment for every adolescent in Nigeria and beyond. Once more, I warmly welcome you all and wish us a fruitful and impactful deliberation. Thank you. Over.
Thank you very much. So we'll hand over now to Onyinye to introduce the speakers, and she will take over as a moderator. Onyinye, over to you.
Thank you very much, my President-elect, PAN President-elect. Distinguished ladies and gentlemen, the PAN President and ESCO, APSON President and ESCO, our facilitators here present, and everyone, indeed everyone that is here. We have introduced adolescents and adolescent health in our first seminar, pointing out the need for emphasis on adolescent health. Today, we have two distinguished speakers that will address our selected theme, which is From Knowledge to Practice, Delivering Adolescent-Friendly Healthcare Services in Nigeria. We're going to be looking at it from the policy end, from the WHO end, and then we will, someone who has practiced adolescent care is going to speak with us. So we have two speakers. The first is Dr. Chimeziri Joy Ufere-Isikima, who is a distinguished public health physician and World Health Organization technical expert with over 2 decades of professional experience, primary health care, adolescent health, and health system strengthening. She has played pivotal leadership roles in the development, the implementation, and evaluation of national and international health programs, contributing significantly to improved health policy formulations and service delivery, particularly for adolescents and other vulnerable population groups. Throughout her career, Dr. Isikima has been actively involved in advancing evidence-based public health interventions aimed at strengthening health systems and improving access to quality healthcare services. She's worked extensively in initiatives focused on maternal, child, and adolescent health, with a strong emphasis on integrating adolescent responsive health services into primary healthcare system. And her expertise spans program design and policies. She is widely recognized for her commitment to improving health outcomes for adolescents and undeserved population throughout scalable and evidence-informed approaches. Her work continues to influence adolescent health programming and policy direction in Nigeria and beyond, making her a respected voice in global public health and adolescent health advocacy. We also have Dr. Folusho Balogun, who is a reader at the Institute of Child Health, College of Medicine, University of Ibadan, and serves as a sub-dean postgraduate for the Faculty of Clinical Sciences, University of Ibadan. She is also an honorary consultant pediatrician at the UCH Ibadan and holds a medical degree from the University of Ilorin with a master's in public health and PhD in adolescent health from the University of Ibadan. She's been practicing as a pediatrician since 2012 following her residency training, and her research focuses on child and adolescent health with a strong emphasis of developing context-appropriate solutions in health challenges affecting young people. She is actively involved in community-based adolescent health interventions, and she provides clinical services and for adolescents. She's a member of several organizations, including PAN and APSON, and she's one of the foundation members of APSON. So we feel she has all the active information in practicing, in taking care of adolescents. So ladies and gentlemen, today we are going to be hearing from these two great speakers. After now, we're going to hear from Dr. Joy Ufere and subsequently from Dr. Folusho Balogun. I don't know if Dr. Ufere is here.
Thank
She's
you.
trying to share her screen.
I'm here.
Right.
I'm trying to share my screen. Okay. Please, can you let me know if you can see my screen?
Yes, we can see your screen.
I can't see it from this end.
Wow. It's here and it's moving.
It's moving, right? I can't see it from
Yes.
my end. Come and help me, just a few minutes. All right. Can you see it?
No.
You can't see it?
No,
Not
not anymore.
Let me go back. It came out on its own. Just a few minutes, please. I opened it before. This is not working. Just a few minutes. I don't know what happened to my system. It was open.
We can see your screen.
Okay, okay. While we wait for,
We can see. Okay now.
okay, we
now.
can see your screen now. But while we wait for her to
Okay.
continue, I would like to announce the presence of our immediate past PAN president, Dr. Ekwueme. She's here with us.
What happened? This one's showing me every time I'm doing.
Dr. Joy, your slides are visible.
Okay, can I go on? Can you all see?
Yes, yes, we can see your slides.
All right. Let me first of all thank you all, the president of PAN, past president of PAN, president of the Adolescent Association Group of Nigeria, the moderator and senior colleagues. And on behalf of WHO, we really want to say we appreciate this partnership. We also appreciate being in this cycle to share a little bit light on the adolescent-friendly health services. And we started this as partner, and hopefully we'll continue as partner to ensure that those adolescents out there, key intervention reach to them as expected in a very respectful manner, so that we'll be able to reduce adolescent fertility rate in Nigeria. Thank you for having us. So for me, not wasting time, I'll just dive into the task that was given to WHO. So this evening or this mid-afternoon, we'll be talking really on the adolescent-friendly health services. What are the importance as well as processes? So my highlight will look a little bit on the global commitments that we have on adolescents, few background, where we are coming from and where we are heading towards. I'm also addressing the importance of adolescent-friendly health services, how we should implement, translating from policy to operationalization. And I'm also happy that a colleague will be talking about what is real out there in paper to action. And then a little bit of assessment that was done on adolescent health services in Nigeria about some years ago, just to have a little bit of what is going on, and then conclusion. So I will start by saying that adolescents, since the setup of MDG to SDG, adolescents have been in the center of conversation. And then initially there was some silence on adolescents, but towards the SDG, there was now some kind of refocusing on adolescents, because we at the global level or global space realized that adolescent is the core of achieving SDG, that's Sustainable Development Goal. And it was based on that at the global space, a global strategy for women and children and adolescents was developed in 2016. And within this strategy, countries were meant to buy into it, to kind of in a way contextualize what the issues on adolescents are. And then to support countries to translate this global strategy to action, the Global Accelerated Action for Health of Adolescents was developed. And it was also bringing up partners in that space to really look at what happened at the country level and how do countries move from strategies to action. So the AHA, we call it the AHA guidance, was more like an operational, a systematic operational level on how country can be guided to implement adolescent to the last mile. And all these center around the SDG, like I rightly stated, because adolescent is core to SDG, and also looking at the World Health Assembly resolution on adolescent, leveraging on the global strategy for women and children. Adolescent was also at the core of this conversation. So the World Health Assembly had resolution that they monitor and track country as they move on implementing adolescent to the last mile. So the background now, let me give a little bit of the background. In implementing adolescent, we're going beyond health. We're looking at the well-being of adolescents. So you will see in some paper, you see adolescent health, you see adolescent development. So we are looking at, because adolescent himself, adolescent is a group that are very heterogeneous in nature. So when you're trying to address the issues of adolescent, you need to look at it at pieces of domains. So in looking at those pieces of domain, you need to look at adolescent in terms of health system itself. how responsive our health system in dealing with adolescent issues. You also need to look at it in terms of the resilience and the agencies in which adolescents work. Because if you look at the causes of adolescence, it goes beyond health system. Okay, so for that, this domain try to tell us, how do we address the issues that come with adolescents? So are we looking at good health and nutrition? And within the good health and nutrition, there are key intervention areas that must be addressed. Are we looking at physical health, mental health, adequate and not excessive nutritional status, and also all manner of things that do with the health of adolescents? Then when you look at connectivity, the value that adolescents bring into the space of society. So even the SDG have said that if you look at some country total population pyramid, you find out that the working dividends are within that adolescent and youth. So we need to invest more in adolescents to have a higher return as we move on. So that level of connectivity, positive values and contribution that adolescents bring to the society is very key, because someone would say that adolescents are the engine house of a nation. Then we look at safety and support environment. You know, this has to do with lots that happen in the space of adolescents. To what level are we providing safety for adolescents? To what level are we addressing inequality and inequity, or the space of social determinant for adolescents? And if we look at also some non-discriminatory measures that have been put to address issues that have to do with adolescents, then we come into the learning and the competency base. That way we talk about education, you know. So in a nutshell, when you're looking at adolescents, look at adolescents from 3 dimensions. You look at the health system, you look at the education, then you look at community. Community is the convention where everything happens. Safety, health, nutrition, education happen for adolescents. So a little bit of this domain is what we'll be looking at, you know, because this domain is not just about how adolescent health-friendly services. We need to look at that health-friendly services. How does it link with other sectors? Because to address the issue of adolescents, you must look at it from a multi-sectorial lens. Because if you're trying to look at it from PHC, you must look at it from a multi-sectoral lens and using community as an entering point. So with that nutshell, I want to say that in Nigeria, define adolescent as from age 10 to 19. This contributes to 22% of Nigerian population. And in every 4 person in Nigeria, 1 is an adolescent, to take to what level of the magnitude of the group we are dealing with. And then addressing their issue, because they are diverse in nation, heterogeneous in nation, in nature, their issues must also be addressed with that lens. And also recognizing that any intervention that is developed for adolescents must be part of it. So there must be a meaningful participation of adolescents. And when I mean meaningful participation, they're involved in the planning and design of that intervention. They implement with you, they monitor with you, they evaluate with you, and they document best practices and lessons from it. And then coming down to the adolescent-friendly services, data have showed us they are scanty everywhere. And even where they are we implementing in line with the standard that WHO have set up for? So what is the adolescent-friendly health services? I want to say that is services that is provided in a manner that makes adolescents free and comfortable and willing to come back after that services is provided to them. It's also services that are affordable, accessible, and sustainable. So it must be driven by government. It's also services that are based on holistic approach with a coordinated relationship that is established between adolescents and the healthcare providers. So whether we are looking at them as healthcare provider in the health space, or we're looking at it as providers within the community, but it must be a cordial relationship between the adolescent themselves and whoever that is providing that services. And it's also services that are not only health related, like I rightly say, adolescent issues goes beyond health. And then it's also services that are more of adolescent focus, so tailored for adolescents, you know. So WHO have also been able to define the characteristics of adolescent-friendly health services. 5 things is what we look out for within this standard to say a health facility is providing adolescent-friendly health services. These 5 standards must be there. 1, equity. All is a services that is provided for all adolescents, all inclusive, you know, to be able to achieve universal healthcare coverage. It's not addressing a certain group of people, and the services are also obtained when needed. So it's a services that is there, available, but reaching to every adolescent. And it's also services that is easier for adolescents to reach out to when they want it. So accessibility become also a very key area. So it's not a services that is very close, but adolescent cannot reach it. So they must be able to have access to it. It's also a services that is acceptable. So those that are providing that those services must be services that the expectation of the adolescent are met. And it's also services that are appropriate. And what we mean by appropriate is that the right services that adolescent needs, because there are some services that adolescents do not need, so you should not provide it for them. But these are services that the adolescent needs that are appropriate to their needs, addressing their preferences and their need. And then the last one, that it is effective. Effective in the sense that it's a services that is provided in the right way, and that it also have some positive impact at the end of the day. And adolescents are in the center of the conversation. So it's a service that is very, very responsive and tailor-made for adolescents. So what are the importance of adolescent-friendly health services? One, it improves access. Improving access, looking at it from the area of quality. So if you're looking at quality sexual and reproductive health, you need to make sure that we go all the way of the standards of what is expected. And when we define quality, what do we mean by quality? It's timely, it is effective, it's completely delivered. So we have a definition when we say quality. So those services must improve access. Then the second one, those services must be set in it must be laid out or designed in a set of standardized measures, whereby if you're providing adolescent services, the service provision must be within standard. Capacity building must be within standard. Infrastructure development must be within standard. And there must be some level of consistency and available at the time that is needed. Then the healthcare provider must themselves play the role of advocates. When they are providing that services, they are not there to be judgmental. They are meant to advocate in a way that the adolescents have an uptake of those services. So you're not there to tell them, why are you coming? Why are you not coming? That's not your right. You are there to be sure that when they come, they will come back again. If there's a follow-up, they must come back for their follow-up. Then is a future seeking. It's also adolescent health friendly services has some important around healthcare seeking behavior. If the services are well provided in a way that adolescents come for it prompts them to be coming back, encourages them to be coming back, it improves their healthcare seeking behavior. Because if they come the first time and the attitude that is expressed to them is courageous, they will come back the second time. So even when they are sick, there's this kindly seeking, kindly healthcare seeking attitude, so they don't delay waiting until where things are worse. Then it's tailor-made, like I said. It is very responsive to adolescent. It's all centered around adolescent and it's tailored to their needs. And must also look at sister health services that strengthen referral. Because when we talk about adolescent healthcare services, it's not on one layer. We move from community, PAC, secondary, tertiary. So that enhancing referral system is very, very important when we are providing adolescent friendly health services. So what standard, when we say we are providing adolescent healthcare services, there is a global standard to provide quality healthcare service for adolescents. So once we do not go within this standard, it is not adolescent healthcare service provision. The standard also tells you what the processes are. What do you look out for as a company when you're implementing adolescent friendly healthcare services? So WHO has been able to articulate these standards. We have reviewed this standard, even at the country level and national level. We have incorporated this standard within our RMNCH quality of care standards. So these are what needs to happen. Now, this standard tells you how to implement, like you say, processes. What is expected while we were putting up this standard, become unified. Those are any state, any PAC, any primary healthcare, any secondary health facility, you are implementing adolescent-friendly youth services. You must align to that standard, because that standard, if you're going back to evaluate or assess what is going on, you are going with the tools of those standards to evaluate. So you cannot tell us you're doing adolescent health services that differ from the one another state is doing or another level of care is doing. So everybody will use that standard to monitor how services are provided for adolescents. So the very first one implementing adolescent friendly health services is kind of identify the issues and the concern. This will now help us develop a unified strategy for the adolescent health and development. Like I say, we are going beyond health to looking at well-being, because the well-being of adolescents is even where the critical issues are. So first of all, what is the issue? The issue that happens in a certain state might not be the same issue that goes to another state. So we need to really identify them. So in making this happen, some level of preliminary review, whether we are doing a desk review, whether we're doing a literature review, because there's a lot of evidence out there that tells us what the issues are. When we're reviewing the national policy on adolescent and young person, what we did some level of situation analysis to really understand, because that policy had been there for 10 years. So we could not have leverage on what was in the policy to start implementing. We said, no, we need to look at, for the past 10 years, what have happened. There are emerging issues. Before, we're looking at sexual and reproductive health as a major cause of adolescent mortality. But now, things are changing. There's a global shift that sexual and reproductive health still is one of the prioritized areas, but mental health, substance use are now topping up. So we needed to look at the emerging issues that resulting to issue on adolescents. So a situational analysis was done. So that guided, and that situational analysis, adolescents themselves were in the center of that whole process. We had to do several focus group discussion. Focus group discussion, we covered about 28 states, bringing about 682 adolescents in this conversation. So what we're hearing in Sokoto, adolescents in Sokoto, were different from what we're hearing from adolescents in Bayelsa and Rivers State. So their needs differ. So there is need to be able to do that analysis to really understand what the burdens are and what the issues are. Then once that is done, we identify key stakeholders and start engaging in some level of policy and dialogue. And that key stakeholders, adolescents, are in the middle of that conversation. So this dialogue tells you, oh, how do we move? What do we prioritize? How do we set up what we need to set up? Okay, you cannot address all the issues, but you need to also, where do we move? Where do we have the highest burden? Because now, for you to address equity, you need to go to the place of highest burden. You need to go to places that is most needed. Are we looking at it from a community level angle? Are we looking at it from primary healthcare level? Are we looking at it from higher level and higher referral level? So you need to really look at those dialogues and see how you bring all the pieces together and kind of prioritize what interventions are. Then the next is to rate stakeholders and then develop some level of service delivery network. The service delivery network in this essence is to know what are the interventions, what are the defined essential packages. Okay, then who do we work with? At what level do we work with? What is the network we are set to? What is the community of practice? What is there? So this also kind of in a way, everybody come in and co-create. When we are co-creating with adolescents with the center. When I mean adolescent in the center, you hear their voice. You hear them participate and not just putting them there to be beautifying tables and be nodding head like chickens that mothers are telling to nod head. No, you hear their voice, you accept their voice, you can actually support. But before that happens, capacity of these adolescents are built to be able to speak. Then we now plan with whatever they have seen. Prioritize, plan, budget, identify activities, where the activities should be implemented and cut for it. Then the next thing you do, step 2, is to conduct a facility inventory and assessment. Here, what we are looking at is identifying the focal point for service delivery. Like I said, we have 3 dimensions of adolescence and everything falls into it. We have the health system, we have the community, and we have the education. So these 3 dimensions, every other thing falls into it. For the health system, which we are narrowing in this conversation, you need to do at what service delivery point will you be looking at? Are we looking at service delivery point in community, PAC, or referral? So this will now guide you to know the level of comprehensiveness of intervention you want to push, the level of coverage you want to reach, and also the level of accessibility of this adolescent. Remember, I talked about the domain, the various domains we must reach out with these interventions, and then strengthen linkages across this whole domain, because no domain stands alone. The domain has some form of linkages to each other. Then the next one, step 3, is to ensure competency training for service providers in adolescent health. One, how do we make this happen? Conduct in these assessments. Are the human resources, are they there? Even if they are there, what are the skills? What are the competencies they have? How many of them are dealing with adolescents? Are there training requirements? Are we going to train all the staff in the different health facility where they are? Because some level of, even when you're bringing them, the staff at the gates is the first entry point on handling adolescents. So if the staff, the gate man in their health facility is not friendly enough, I'm telling you, the adolescents might not even come into the compound of that health facility to take services. So you need to understand, who do we train? How do we train them to support adolescent-friendly health services? Then apart from training that level of healthcare workers, that health facility we are looking at, we also need to map, identify where are the levels of referral. Who, if you refer an adolescent from one level to another, the people you're referring them to what level can they accept? What's their level of capacity to really accept the adolescent and handle the adolescent and that adolescent expect to be handled? The next thing is step 4 is strengthen training.
Thank you, Dr. Joy. Begin to summarize, please.
So strengthen, we need to strengthen those training, we need to strengthen to ensure quality improvement. Establish a system that informs the adolescent and the youth about access. So there's also need to be able to work with the adolescent and the champions to be involved in planning, developing, and implementing. Build their capacity and as well as disseminating information that is very useful to them. Then there's a processes. I have this schematic which I can share, but when you're looking at network of strengthening intervention for adolescent and young people, those networks are there for you to know how to refer and where to refer to, and protocols that are needed. And then there's key to monitoring. We must monitor. Indicators, standards must be there for us to monitor what we are delivering. We have the vertical indicators and horizontal indicators. The vertical indicators look at the program area, the chains. How do you do program costs? Then horizontal indicator looking at the service delivering themselves within the health facility. And then the guidelines of what is needed to provide for adolescent and youth-friendly services, establishing a rapport, ensuring confidentiality, including family, understanding the roles and responsibility, and active learning. Then the characteristics of a good adolescent health services provide that they are trained, not judgmental. They will treat the adolescent with respect and provide comfort. Ensure that every information that the adolescent provides is secret. Ability to communicate simple terms, friendly, empathy, and is also a good listener. Characteristics of the health facility itself must be convenient location. You can't take it very far from there because of access. Flexible opening hours. They can walk in anytime they want and get services. Availability of space and surrounding. Let them be free, move around and engage as much as they can. Then basic equipment and supply, as well as supporting resources. Assessment was done by Federal Ministry of Health on adolescent and youth-friendly services. We realized that 55% of these services are provided by partners and NGOs. And less than 1/3 of the staff do not have any special training on adolescent-friendly health services. So overall is that half of those services we did, some are kind of integrated, while some were solely particularly different. Some people will just go and get a structure and call it adolescent healthcare services. But WHO is saying now this intervention must be integrated into the system itself. It must be integrated into the health facility. So you don't need to put a separate structure to say this is adolescent health friendly youth services. No, integrate it, build the capacity in a way that is a system thinking thing so that they can feel free when they come in. But people must be trained, healthcare workers must be trained on knowing what to do. So I will just conclude by saying that providing health services for adolescents and young people is a sensitive public health issue. And these services must be within standards and quality that these adolescent young people are seeking. So it's not something, the public health issue is very sensitive and how we address it is very, very sensitive. But at the same time, whatever services that we provide must be standard. So we should look at it as an entity on its own. It must be integrated into the system and it must be standard and monitored to see what is coming out of.
Folusho. Can you share your slides? Dr. Balogun.
Yes, I'm trying to share it. Can you see my slides?
Good. It's coming up. Yes, we can see it now, but it's not on slideshow. Can you make it slideshow?
Yeah. Good afternoon, everybody.
Good afternoon.
I'll be talking about adolescent-friendly health services, experiences from the clinics. I'll be using this outline. We've been told who an adolescent is and what their characteristics are. And then I want to define health. Like we all know, it's a state of complete physical, mental, social, and spiritual well-being. Please let's look at the mental and the social aspect, because many times when we see our patients, many times we just look at the physical. For adolescent-friendly services, the mental, social, spiritual are all important. Health service is what a healthcare worker will provide, and there are two complementary roles that they play in adolescents' life. One is to keep them well, and that's why prevention, we all know, is better than cure. Many times they get into health problems, they develop health problems because they are ignorant or they did not know any better. Ill adolescents get well. But from experience, most adolescents that come to the clinic are physically well. They have problems in other aspects of their lives. So please, I want to let us know that adolescent-friendly health services is not equal to sexual and reproductive health services. They are two different things. But because Africa did not really have any focus on adolescent health until HIV started, and to control it, sexual and reproductive health services were now being taken seriously for adolescents. And that's why right now, many people, when they hear adolescent-friendly health services, the first thing that comes to their mind is you are distributing condoms. Please, this is not true. And this is a summary of the adolescent health problems that we usually see. And you can see that sexual and reproductive health problems is just one of them. Why adolescents important? We'll be told about the percentage of population that they constitute, which is significant, and also the fact that this stage is the critical window for the development of either a healthy or risky behavior, which can affect the adolescent now, adolescent in future, when they're adults, and their future children as well. And this is why an investment in adolescent health has been described as double barrel investment that can have triple barrel outcomes. I want to sincerely thank the 115 Nigerian pediatricians who took part in a survey at PANCOF in January 2024. And you see some of your response in this presentation because it's really important, it's relevant here. And the pediatrician reported that they were seeing 32 adolescents per month in their practice. And the median age of working with adolescents is 12.8%. It's 12.8 years. We excluded neonatologists from this study because of the assumption that it's not likely they see adolescents. But the truth is, neonatologists at one point or the other will have to deal with adolescent mother and adolescent parents. So technically, all pediatricians in Nigeria see adolescents. And that's why this is very important to all of us. This is just to show us, I apologize, I didn't get a more recent picture that will show what I want us to see. But I just want us to see that in Africa, the mortality among adolescents is highest in Africa. And you can see it's more at the age of 15 to 19 years. So it is very important. What are the peculiarities of adolescent health problems? Many of them have psychosocial problems. And some who do not even have, who appear to have just medical problems, have some psychosocial components to their problems. And the good news is that many of them are preventable. Also, adolescents come with either partial or no autonomy, depending on the stage they are when they come for healthcare. And because of that, it affects the way we take healthcare decisions with them or plan their healthcare management. And their health-seeking behavior is also influenced by some of their characteristics. Having a sense of invincibility. They believe they can handle everything, nothing can get to them. I once had a 15-year-old that had dog bite, and he was telling me that he has Googled and he discovered that since the dog was vaccinated, he doesn't need to have any treatment. At least I was happy that I was able to convince him to get his vaccines. And then secrecy is a characteristic of adolescents. And because of that, sometimes they may not want to volunteer important information when they come for healthcare. An immature decision-making process, which is no fault of theirs, it just showcases the level of maturity of their brain. The earlier speaker has spoken about characteristics of adolescent-friendly health services, so I will not dwell on this. This picture shows how adolescent-friendly health service is. It's a building, and you can see that the foundation is formed by the provider attitude. So the way we see adolescents, the way we handle them is very important. And if the foundation is wrong, everything will be wrong. The middle part just shows the different compartments in which adolescent-friendly health services can be provided. And I'm sure that most of us listening here are either in the public sector or the private sector where we provide our services. And the roof is the characteristics of the friendly services that I discussed earlier. And that is what protects everybody and brings everybody together. So what are the characteristics of an adolescent health pediatrician? The first thing is empathy. We have to understand and share the feelings of the adolescent. This is a major way of connecting with them. And then communication skill is very, very important. We have to be good listeners, patient listeners, and also be able to present messages in a way that adolescents will understand and accept. And then we have to have a good knowledge of adolescent development, because we classify them into three: early adolescence, mid-adolescence, and late. And the way they process information at the different level of development, it varies. So we have to tailor our management and our messages in a way that at any stage, they will be able to comprehend what they're talking about. And then we have to be patient. Adolescents will try your patience as a physician. We just have to, accommodate them and also be flexible. In terms of patience and flexibility, I once had an adolescent that came to the clinic. My clinic is still up to 24 years. We call them young people. So she's 21, and the first encounter, she told me she does substances. The second visit, she brought marijuana to the clinic. And I was like, why? And she said, because she felt I didn't believe her, she wanted to prove that she does. The typical Nigerian adult will have, maybe play her up or start, all those funny counseling and that don't really work. But, I was able to compose myself, and we were able to arrive on the fourth contact. We were able to arrive at our diagnosis, and we started working from there. And then holistic approach is very important, because even when they bring medical problems, many times there are some undertones that, if not addressed, we will not have good results. And confidentiality awareness is very huge for adolescents. When they know they can confide in you, then your work is like half done. In my center, in the Institute of Child Health, this is a summary of the services we provide, the clinical services, and then we also have community services, because both just have to go together, else we will not have results. So we work with schools, we train healthcare workers, especially Oyo State nurses. In the last 10 years, we've been training them when they have their continuous medical education in the adolescent health issues. And this is a picture showing our students who, one of their health talks that they went to do in schools. So the typical adolescent consultation process requires about 60 to 90 minutes for effectiveness. The first step is to welcome the adolescent to the clinic, introduce yourself, and then adolescent introduces other people present, all the caregivers. Why? This is an adolescent health clinic, and the focus is on them. Many times you even be surprised that that's the first time ever that they will actually be given recognition or audience. We want to build their self-confidence and also make them feel welcome. And then we spend time with the adolescent, spend time with his caregiver, and then at the end of the day, spend time with both adolescent and caregiver, and then you wrap up your management. Lesson learned over the years: emotional maturity is key. If you are not emotionally mature, you cannot make a success with consulting with adolescents. And then there should be a balance between personal beliefs and values and standard clinical practice. We have to separate these two. Many times, the typical Nigerian adults, you will say, oh, you have to do this, you have to do that. It doesn't work that way. You've been told about the standard that obtains. We just have to maintain that standard if you want good results. And then skill development, you cannot downplay that. I had to do so many personal development things, having online classes. There was a time I went for observership in the center that has standard adolescent health setting. And then also all staff need to be trained, from the gate man to the cleaners. One bad egg is enough to destabilize the whole clinic and make adolescents run away from your clinic. And then you learn from adolescents, learn how they interact. One of my favorites is to learn slangs from them. And then sometimes when you are seeing them and you use their slang, you see the change of their face, and their brain will be like, this one's a bit. And it's one of the ways to connect with them. And then handling parents. Parents come in different baggages. Some of them, they're even more anxious than the adolescents you are handling. So if you don't address their needs, you may not really make much progress. Some of them believe that some of your interventions against their religious belief. I once had an adolescent that had compulsive gambling. And eventually I discovered that one of this problems is that he's an introvert and doesn't have much extracurricular activity. So to help him, we decided to like plan this. I can add extracurricular activities to his management. It was a third consultation that we discovered that they were not going to buy into any of that because the father is a Muslim and he believes that indoor games are against Islam. So we have to give him money to buy football, and that was the extracurricular activity that I started with. And then we have to collaborate with NGOs. There are times you just need them. I've had a case of a 12-year-old that was about to be molested in a foster home. And the girl contacted one of the nurses that we have trained. She called me. I had to call NGOs. And fortunately enough, so many triggers have been set up. The civil defense people were the ones that rescued the girl eventually. So we have to just do some collaboration to get things done. This is also from the response of Paediatrician, and this is the score sheets for adolescent friendliness in the centers which they operate. I leave us to decide whether this is acceptable or not. So I decided to talk about how to address the barriers in providing adolescent-friendly health services. And from the response of the 150 pediatricians, you can see that insufficient training in adolescent health was like the major barrier that they encounter. And this is another study, an earlier study among other healthcare workers, apart from pediatricians. There were family physicians here, adolescent psychiatrists here. And you can see that lack of skill was a major thing that was mentioned as a barrier. So what are the sources of skill that we have right now? Our undergraduate and residency training do not really focus much on adolescents. The other training also that are donor-driven, but most of them are focused on sexual and reproductive health services. At the University of Ibadan, Institute of Child Health, we have a master's in child and adolescent health and PhD in adolescent health, which can help to some extent to fill this gap. These are also other resources that we have available. The first text is written by most of the authors are from APSON, and the second text is written by so many authors from different parts of the world, and the editors are my teachers. We also have this from the Ministry of Health, and then also at the global level, different texts which are freely available online that can help in our practice. Then there are international opportunities. London School of Hygiene and Tropical Medicine, they have this yearly training, but it's pricey. If you can get sponsorship or you can pay, it will be a good one. And Coursera also offer global adolescent health course, which you can audit for free, but if you want a certificate, you need to pay. Or you can justify your application for a scholarship and you'll be granted. Most fellowship in adolescent health take place in institutions in North America. Example, the University of Boston, I put that there because that is the center where adolescent health started in 1970. Hospital for Sick Children in Toronto, that was where I had my observership. And then University of Melbourne in Australia, they offer fellowship, up 2 to 3 years of fellowship in adolescent health. Barriers experienced by pediatricians also include lack of resources, staff, drugs. But we can actually train our staff when we ourselves get trained so that we can have effective adolescent health services. And then prolonged consultation time, except we have more hands, we cannot compromise that quality. For clinic setting, we can rearrange our clinic setting to create a corner for adolescents for privacy, and that will go a long way. And then protocol for correct handling of adolescents, we can develop that based on our skills that we can gather when we get trained, and not cooperation of adolescents. From experience, this is because the healthcare workers do not understand them. The other problem that we have is we don't have unified cutoff age for teen adolescents in pediatrics. From the cohort of the 115 pediatricians that we studied, the age range of cutoff from teen adolescents range between 10 and 20. That's huge. So if you cannot agree on a cutoff age, then there's a problem. And then we don't have transition care when they move from pediatric clinic to adult clinic. And that is one of the reasons why they don't do well when they get to adult clinic. And then we have a lot of problems with privacy, confidentiality, and then co-planning of management. You have to co-plan management adolescents for it to work. We don't do that most of the time. And then psychosocial factors. Many times in our conventional clerking, we don't look at psychosocial factors. This is a case series report of 3 patients that I saw at different times. One with recurrent headache, another one recurrent headache with redness of the eye, another one recurrent GI and respiratory symptoms. It was when I conducted psychosocial history, that I discovered that all of them were not sleeping well because of excessive use of smartphone. And they were
Thank you, Dr. Balogun. Can you start to summarize, please?
Okay, thank you. Between 2 to 4 hours for months. And then when we started using promoting responsible phone use, their symptoms disappeared. This is the common psychosocial history screen that I use in my clinic, and it's really helpful. It's online. So in conclusion, institutional self-development adolescent health is very important for all pediatricians. And health services provided in Nigeria currently are not really adolescent-friendly, but we can use available resources and maximize them to provide these adolescent-friendly services. I recommend that curricula at undergraduate and postgraduate should have more focus on adolescent health, and we should create more avenue for training for adolescent health service provision, and also advocate for inclusion of adolescent-friendly concepts in the development of health infrastructures. Thank you.
Thank you very much. Thank you so much for your presentation. Again, she has spoken from passion. You can see that she has brought all her experiences with consulting and seeing adolescents. But a lot of issues has been raised from all these presentations. The first is that we need about 60 to 90 minutes for a very good consultation with adolescents. And I'm wondering how we can do that with the current brain drain of doctors. So I'm going to look into the chat room to see if there are any questions. And if you want to ask a question, you could also. Okay, no questions in the chat room.
Madam President, your hand is up. You want to speak?
Yes, thank you very much, the PE. I thought maybe it was my own network that was bad. So I want to start by apologizing for not being at the beginning to give my address, because I was in one of those many meetings from Abuja and my flight kept being delayed. And after I got down, I was trying to connect on the way and it wasn't. But nothing was going to stop me from keying into this very nice webinar from APSON, our tier-rubber subspecialty. So thank you very much. Ably led by their president, Dr. Bridget. I want to thank the speaker, Dr. Joy, very passionate, and Dr. Folusho. I have really learned a lot, and I knew it was going to be interesting, and that's why I joined as soon as I could. So somebody once told me that we think that the early years from 0 to 5 are difficult until we meet an adolescent, or when we begin to encounter adolescents in the clinic. And from this presentation, I really have learned a lot. It actually justifies it, but I also learned so many ways in which we can address it. And I'm thinking there are so many things that are packed into this webinar right now. So I want Dr. Joy and Dr. Folusho to please just give us like 2 or 3 take home for all the many pediatricians that are listening today, how to, should I say, set up an adolescent clinic, because I'm sure many people after this will be joining our adolescent group. So well done, everyone. And it's been, I'm enjoying the session. I don't think Dr. Onyinye is, I'm not sure if she's still here. So PE, you might continue the moderation.
She's having network issues.
Yes.
So like you rightly said, Joy and Folusho, could you just address what the president has said? take-homes for setting up adolescent clinics? Because I'm not sure I can spend 60 to 90 minutes talking to an adolescent.
Very interesting.
I must say that Folusho is very brave to see an adolescent coming with marijuana. You start down there quietly.
Honestly, so much is being shared.
Can you assist us with that?
If I may start, Mr. President or Miss President, I don't know how to address my sister. Thank you so much. And it's just how amazing you just left Abuja with a few hours ago and you're already joining that meeting. Thanks so much. For me, my takeaway in setting up adolescent health, I won't call it a clinic. I want to say is really understanding that adolescent issue is heterogeneous. Like Dr. Balogun mentioned too, from what she experienced. So once an adolescent walks into your health facility, just don't assume that that adolescent is coming because he or she is sick. No. So in setting up adolescent health service, adolescent-friendly health services, you need to really understand what is there in your health facility. What infrastructure is there in your health facility? That's the very first thing. Then the second thing you need to do is to do some level of analysis, quick analysis. The adolescent around the setting, what do they come more with? What do they present more with in the health facility? You can use your data to know what exactly do they present with, okay? And for you to even be able to know, you need to also know the data in terms of disaggregation. We say adolescent is 10 to 19. That's what we said. Now you find out in some health facility, the younger adolescent, which is 10 to 14, falls into pediatrics. And then the older adolescent, which is 15 to 19, falls into general outpatient. So you really need to understand, for you to catch this adolescent for that age, how will you restructure to make sure that you're meeting the holistic of that adolescent in terms of the age? Then what kind of infrastructure do you have available? Okay, so for WHO, we always say, don't set up a separate structure for adolescents. Integrate them into the whole service, because now we don't have enough human resources. So because some human resources you're seeing there, how do you maximize them to be able to deliver? So what do you have in your infrastructure? What do you have in your setting first? What are the diseases that adolescent comes with? Secondly, then how do you disaggregate? How do the age cohort? How do those interventions within the old cohort comes in? So you need to have this quick assessment to be able to know your layouts. And then what are the data that you have available to be able to cater for this age group? Because some data tells you information. What you don't report never happen. But you must make sure you have the real data element across this age cohort to be able to get what you want to get. And then the last but not the least, the capacity of those delivering these services. Because if you're looking at services that are being delivered, there's no problem about services that are being delivered, because sometimes WHO have those standards. You just integrate those standards into your SOPs. But the people delivering these standards for the adolescent, to what level have their capacity been built? We're saying that we're having Japan syndrome, doctors are going, healthcare workers are going, but the ones available, to what level do they have that competency, that mixed competency to be able to deliver? And not just clinical, because once an adolescent comes in, look at the different domain of adolescent. When you're clack with an open heart, not being judgmental. You will find out that adolescent will tell you they have headache. It's not headache they have. I'm telling you the truth. By the time you finish exploring, you'll find out that it wasn't really headache that brought them to that health facility. So you just being able within your own setting, what is available. Then how do you disaggregate the adolescent themselves in terms of service provision? Who are the skills that's available to make that happen? You know, and then what is the data that tells you what you need to do? So this is just in a synopsis what I can say. Thank you very much.
Thank you very much for this question. I apologize. I think I gave a wrong information. The 60 to 90 minutes is usually for adolescent coming for the fourth time. Subsequent consultation is usually less than that. But there are some situations in which even after the first consultation, you don't really have head or tail. Like I said, many times, the first 2 visits is to assess whether they can trust the healthcare worker or not. Until that trust is established, usually you not hear the truth. So the more reason why we have to be patient, and then we can actually organize our system in a way. The first thing that is important to make our services adolescent-friendly is all healthcare workers dealing with adolescents that will have any contact with adolescents need to be trained on what adolescent-friendly health services are. If you don't start from there, by the time the adolescent gets to the gate of the hospital or clinic, sees the gate man who looks at the adolescent somehow and says, what is this one doing here? Yeah. And then gets to maybe where the ward assistants are, adolescent is now treated somehow. Before they get to you, they already have some wrong impression about your hospital or your clinic. And that's why all your staff needs to be trained. That's the starting point. After that, whosoever is in pediatrics should get trained. Like I said, at one point or the other, we will all have contact with adolescents, and we have to know how to handle them. And then, to me, once we have that training, and we are all on the same board, whosoever is now designated to see adolescents may now have some cases that need to be seen, referred to the person. For example, if I'm running a sickle cell disease patient, the adolescent is there because of sickle cell. But this adolescent is 14-year-old. And I think this adolescent is having some issues that I don't really understand. It's not complying with the drug, not really coming for clinic. It's better you send that adolescent to the person who is in charge of adolescent health, because that person will know what to do to address this non-compliance and not being consistent in clinic. That's one of the things I think we can do right now, instead of now trying to establish one, maybe program to do that. But all our services across board should be adolescent-friendly. Thank you.
Okay. I'm so sorry, I was thrown off by network.
Okay. Sorry, before Bridget, there's a question here. Can the Ministry of Health help provide materials for promoting adolescent health? And then secondly, Folusho, is there a separate setup for the POPD for adolescent health? So can you 30 seconds each answer that, then Bridget can then speak. Thank you.
Sorry, so what's POPD?
That's pediatric outpatients.
Okay.
Since the usage is there a separate setup from the POPD for adolescent health.
Okay. I'm in the Institute of Child Health. Before, we did not have any separate adolescent health clinic. And when I started there, so that my adolescent will not be feeling somehow, seeing an infant, a 1-year-old, and be in the same clinic with them, we decided that we're going to have an adolescent health clinic. In the meantime, I see my patients in my office. It's more convenient for me, the privacy is there, and the setting is more conducive. But right now, we already have a space earmarked for adolescent clinic. Right now, we are looking for funders. We got some who are already interested that will help us to put the place in order so that our adolescents will be seen in that particular clinic. It's just to make them more comfortable, and then they have other things that they do in the clinic. We plan to have an information corner in which you can put health pamphlets. We want them to have PlayStation. Some of them just want to come and relax. It's not that they are coming with any complaint. So we're actually setting up a separate adolescent health within the same building, but designed, and we're going to actually design it with their input, because one of the things about adolescent is co-creation, co-planning. We are going to invite them, and they will tell us how they want to be, and we want to set it up like that. Thank you, sir.
Thank you very much. There's a question for Joy. Can the Ministry of Health help provide materials for promoting adolescent health?
Yes, Ministry of Health, we have WHO has supported Ministry of Health with a lot of materials. When we say material for promoting adolescent health, we have so many different materials. So just for me to know what and what you need, and then we can see how we make it available, neither on a share link, so that this community can have access to it. Because what is actually expected is that once those materials are produced, professional associations should have access to them to use them. So I will try and talk to ministry. The ones I have, I need to talk to ministry before I share.
Okay, thank you.
Okay, sorry.
Okay, go ahead.
Okay,
Dr.
I
Onyinye.
wanted to ask Dr. Joy, since one of our main barriers is insufficient training, is there funding for training of healthcare workers and pediatricians in particular to be able to attend to adolescents from WHO?
Let me start by
Is there
saying that.
training?
Let me start by saying that WHO have a lot of training online because right now,
Okay.
I want to say funding is an issue right now. We have the WHO Academy platform. So there's so many training online on adolescents. So what I can do is to check the academy and also share a link. And some of these online training are free. You know, it's just for you to register and have a registration is also free. You just knowing how to access that platform, and then I'll share with the community. So I won't restrict, because what WHO is doing now is that remember, some of these documents are also WHO. So countries are expected to kind of get a generic, you know, kind of contextualize it because the content are generic. So sometimes countries are expected to adopt or adapt. But I know professional associations are also part of the members when we adapt these training materials. Professional association representatives are always in those conversations. But if you also want me to share the academy platform for your community, why not? I'll make that happen. So you guys can really go in there.
Thank you so much. Thank you. I heard Dr. Kwagule has a question.
Thank you very much. Actually, apart from questions, I just want to add that the Ministry of Health actually have done a lot, but unfortunately it's not getting down to the grassroots. It's not coming down to the states and the local government area. I remember for the first time, I was director of family health, and the adolescent health unit was under me. That was where I picked my interest on adolescents. And by the time I came to University of Benin Teaching Hospital to retire, I discovered that nothing was being done on adolescents. And I asked the professors and the consultants. They were all looking blank, not knowing what to tell me. So I started the process. I even wrote a proposal to the CMD then to ask how we can start an adolescent health clinic. But it didn't move further, because to them, it just strange to them, adolescents. However, the first time I made a senior registrar to present the first presentation, they were all shocked and surprised. I brought all that I had at that time, about 12 booklets, different booklets on adolescents, starting from advocacy, all sorts of things. I remember Professor Hyomba recalled me and said, Bridget, where are all these things coming from? I've never seen anything like this. I say, yes, that's the problem. But you go to the ministry, they are all there, rotting away. They are not distributed to the state. And I challenge them. I say, why do you people keep all these things and you don't distribute to the state? Because the state don't even know we have all these things. So you say it's becoming a reality on us that, look, we have to move forward. We have to change our pattern of doing things. And I advise them that we normally have this Health Council on Health twice a year, where the permanent secretaries of all the states, the director of health, of public health, and I think one other body, 3 people from that state, we attend. Why don't we use it as a means of talking about these silent areas, adolescent health, geriatric medicine, and some other areas? So they promised me they will do that. I said, they said the problem is that how can they start carrying it? They don't know how to carry it to the state. And when you call them, they will be asking for transportation and the rest. And there's no budget for such things. So, and I said, okay, fine. You have to commit the state. Make sure that they come for this Council of Health meetings and let them carry all the things that we need to give to them. That's the first thing we have done in Ministry of Health. But generally, we can now see that from the statistics the presenters have given to us, that many people are ignorant of the special needs adolescent health. And how do we now make them to know? We are also trying to see how we can develop a curriculum recently and see how we can take it to the National Postgraduate College and the West African College of West African WAEC, West African, what do you call it now? Sorry.
College of Physicians.
The College of Physicians. So that they can look into it. And from what you know, they may also have specialty and add or reduce from it. And then make it also known. Maybe that will also encourage residents to begin to be interested in adolescents. That's one. We also have a community that there's a community. When I was in the Ministry in Health Services Department, where all the CMDs come together. Another thing I want to teach them is that, see, adolescent health is an issue. Please make sure that you have an adolescent health unit in your hospitals. I'm glad now that University of Benin, they've already created one, and very soon they will start. And I pray that they will be able to meet the required standards. So first of all is the awareness. After the awareness, then the training. Many don't know what it is to train an adolescent and how to take care of them. They don't know how to manage. Many of them have not had any training of any sort. So how can they manage them well? And this sensitive group of people, you talk to them anyhow, tomorrow they will not come. Adolescents cannot come to the clinic, sit down, be waiting for 1 hour, 30 minutes for you to see him or her, and he is not doing anything. So there must be a facility in that clinic, either a television or a small library by the side where they can read, just to occupy them, to make them have fun. Their own is the social aspect is very, very important. So we must all come together. And I pray that we APSON will be able to make sure that we break through and make adolescent health more important in Nigeria. Thank you.
All right. There's a question in the chat room that says, do we have other subspecialties in the clinic while we are running adolescent clinic? And I would like to share our own experience down here in the Southeast. Initially, when we run the adolescent clinic, we had mental health physicians and psychologists, nutritionists join at the clinic until we had first space constraints, and then most of the staff jackpot. And so we had very few doctors. Initially, the psychiatrist would send one senior registrar, and the dietitian would send one staff until we had reduction in staff. Then we started running the clinic alone and referring the adolescents to receive care from all the different subspecialties that they receive. However, I would like Dr. Balogun to share with us what happens in UCH and also attend to this other question. What is the first thing that usually breaks down when we try to implement adolescent-friendly services? Dr. Balogun.
Thank you very much. So the way we run our clinic now, we don't have the luxury of having the other subspecialties being present. And it's important for us to know that adolescent health is multidisciplinary.
Yeah.
So the way we go around that is I already have doctors in different parts and also support staff in different parts, and I refer them so we co-manage at the end of the day. Okay. And sometimes you have to schedule meetings to discuss specific patient management. Case. That's how we survive. So the first step to starting this thing is to get the management buy-in, because you need their support. You really need their support. So if you can get the management buy-in, then to me, I think every other thing, you can sort them out one at a time. But we should not wait until we have one big fund from somewhere. And that's why I said, right now we can start implementing this by just adapting this adolescent-friendly concept into our current practice. Thank you.
Yes. Okay. How about the first thing that breaks down when we try to implement?
The first thing that breaks down is usually that connection with adolescents. Okay. If the healthcare provider is not skilled on how to handle them, they are not likely to come back. And one of the things that makes them to keep coming back and even send their friends to you, or parents will refer their parents to you when they see the results.
Yeah.
And usually it's usually, because they'll be like, we've tried all this. In fact, parents keep asking me, I've told the adolescent this before. How come the adolescent is listening to you and not listening to me? And what I tell them is, I'm speaking their language. You don't understand that language. So they will not say, adolescent, But, you have gained their trust. And that's how many times our new patients come in because of referral from existing parents or patients. Thank you.
Let me also add that sometimes you may have to do home visits to these adolescents. And in my experience, I've seen that it makes them feel seen, that you can visit them at home and you can call them. Some of the adolescents have actually wanted to take their lives, and just by coming to adolescent clinic, they have been saved. But I have one now whose father is a doctor but was being forced to read medicine. And so she chatted me up at midnight one night, and I had to intervene. And today she's almost graduating from, I think, computer science in one big university. So just these little things and little diagnoses like acne can be a huge problem for adolescents. So when they come to the clinic, they don't have to come with malaria. They don't have to come with big issues. You have to take time to tease out those little things that are issues to these adolescents. There are no more questions in the chat box and no hand is raised. I would like to hand over to our President-elect, Dr. Eletu.
My hand is raised. Moderator, my hand is raised.
Okay, let's hear from you, please. Thank you.
Yeah, sorry, I won't waste most of your time. I think also we need to really understand that in dealing with adolescent friendly services, there's a linkage to the community. So I'm just leveraging on what Dr. Onyinye said, moderator. When you're dealing with adolescents, you just don't stop at the clinic. That linkage between adolescents, the clinic, and the community, the household, is very, very pertinent. So that's why we also say that health system, responsiveness of health system toward adolescents is very key. Not just adolescent-friendly service delivery, but the system itself being responsive to adolescents. That's where the linkages to community is. So like I rightly say, most adolescents walk into your clinic not because they are sick. They don't know where to enter because health facility become their entry point to express themselves. So once that exploration or that conversation is done between adolescents, we need to support a linkage to the community to know what is happening at home. So it's very, very critical. So I just wanted to drop that. Thank you, Onyinye, for bringing this up.
All right, Dr. Joy, there's a question in the chat box. It says, is adolescent care service at the primary health care level? I know you had mentioned all the levels, the primary, secondary, and tertiary. Is it available at the primary health care level?
Okay, the primary health care, when you say primary health, there are two different things. Primary health care level and primary health care, there are two different things. At the primary health care level is looking at continuum of care, where you have from pregnancy to newborn, child, and adolescent. Yes, adolescent health services are within the primary health care. But what happens is that it's an integrated approach. So you're not going to separate it. So look at it from the length of continuum of care. Okay, so those interventions that might be given to primary health care, adolescent health friendly services at the primary health care, you might not see a separate structure because some primary health care might just have 2 rooms.
Yeah.
So you might not see that structure. But the interventions, what is more important is that healthcare worker trained on how to manage adolescents. So because some adolescents, remember we have adolescent pregnant. There's some adolescents that the older adolescents of 15 to 19 who are pregnant, who come in with pregnancy. So the way you manage them, you don't manage them the way you manage a normal woman because they are within the productive age. So you still have some tailored intervention for that adolescent. But is that healthcare worker trained to be able to separate adolescent services and normal services? That is very critical at the PAC.
All right. Thank you so much. Thank you so much. The PAN President-elect, Dr. Eletu.
Thank you very much, and I want to seize this opportunity to thank our two erudite speakers, Joy and Folusho, for the wonderful presentations you made to us today. I'm sure most of us who will be shying away from adolescent healthcare services are now a bit better equipped, and we can start offering care. But just before we do that, I think we also all need to go and learn the language of the Gen Z, Gen Y, and the Gen Alpha.
Yes, sir.
Because if we don't do that, obviously, when they speak to us,
You can't communicate.
Understand what they're saying. So there'll be communication barrier. So some of us will obviously call Joy and Folusho later on to get some experience, share some experience with them as to how they can also help us manage some of our own patients. And particularly for some of us who still have young children or adolescents at home. I mean, when they talk sometimes, I'm like, what are they saying? I don't understand. So we need to still learn from the experts. So on behalf of the Paediatric Association of Nigeria, the PAN president and the ESCO members and other members, I want to thank the Pediatric Adolescent Society of Nigeria for this wonderful presentation given to us today. And obviously, we look forward to hearing from you again, hopefully within the next 6-7 months. It will be your turn to give us another nice dish of pediatric jollof rice, adolescent pediatric jollof rice. So thank you.
Thank you.
So we look forward to see you again next month when it will be another society that will be presenting to us. Thank you all. Have a wonderful evening. God bless you all. Bye for now.
Thank you. Please, we need more.
Thank you.
Okay, thank you. Onyinye, please, I will share my presentation with you for the rest of the community. Share your.
Yes, I will. Thank you.
All right.
Thank you. Thank you very much.
Thank you. Joy, you soon join PAN.
We need more members. Men, especially the men.
Men.
We need more male members in adolescents.
Okay, don't worry. We'll join you.